Thank you, Dr. Thank you for the opportunity to present here in front of all these stalwarts. Thank you for all the learning so far, all a couple of good cases there. And like you mentioned, this is something which is very common, although very rarely reported in the literature, probably because of Dr. Namrata Sharma showed the prevalence to be just 0.016 there. And this is a case from like a couple of years back when I had just started to take baby steps in my refractive surgery. And when I became quite confident that I was reaching there and the surgeries were coming easily to me, this gentleman reported to the clinic, and he had a very low refractive error to present with, and the scans were absolutely normal. Mind you, I did not see this patient in the clinic, and the patient just reported directly to my OR, and the patient had opted for a microkeratome LASIK. So the mean K there is 44, and had a good, the similar kind of scans in the left eye. Corneal diameter was around 11.8 millimeter in the right eye and 11.7 in the left eye. We have the Moria and the single pass, single use SBK. So as per the nomogram suggested by the Moria, the ring size was 1 and stop preferred was 8. The blade size was 130. So this is how the right eye surgery went. The right eye surgery was quite uneventful. Uh, uh, when I noticed the patient pre-operatively, the patient had a deep set eye, and I usually explain all my patients before taking up for surgery that cooperation. Okay, great. So this is a left eye. As you can see, the patient has a deep set eye. I'm just trying to fix my ring there and trying to have that perfect white color rim of conch visible. When that was very well aligned, I just applied the suction there, and when the blade was passed, I did realize something went wrong. When the two pass was there, I felt something was wrong, and I could feel my suction ring loosening up. And I realized later that the suction had lost entirely. I could see the patient's eye, the proper bells which was there, and I could not see the texture of the cornea was different. I did not see the flap over there. I did not discard the or I did not put away the blade over there. I just noticed the flap near the blade. I just use a vexel to pull my flap out of the blade, and so and this was very scary moment at that point of time. I was very nervous because I had never seen a flap being free flap being managed, leave alone a free flap being present in the blade, your microcurrent blade, and so I just placed the flap back again. I was the multiple thoughts were running there. What do I do? How do I proceed next? Whether I proceed with the ablation, or should I just place the BCL and then leave the patient and probably plan a repeat procedure, preferably a PRK later on. So I just tried to keep the flap uh, back to its position on the surface of the cornea, and when I felt it was like adequately placed. I had just a couple of questions in mind at this point of time. When I was using Vexel, the first question that came in my mind was which side is epithelium and which side is stromal, and how do I fix it if I place it reverse? Because the patient had only a spherical error, just point five of cylindrical error in the right eye and just purely spherical error in the left eye. So the couple of questions that I had, which was the somal side and which was the epithelial side, how do I decide that one? And there was a lot of stromal hydration during the entire process. And should I like proceed with the ablation? Would I undercorrect the patient or not? So when these questions were running through my mind, I simply decided I'll ask the patient. I just informed the patient on table that this is something that has happened, and I took consent from the patient, and he said that you can just go ahead. And I told him that if any residual error is there, we can just probably try to correct him later. So I struggled with the flap to understand whether which side was epithelial or stromal, and I did realize that the stromal side was a bit stickier. So I just replaced the flap and placed the epithelial side up and the stickier side down. After probably a 5 minutes of manipulation, the good part about the free flap loop was that this part was a bit sharper. It was not exactly round, so I could orient my flap. And this is the time where I did not. This is a patient where I had. This was the only patient where I did not mark, and I instantly had a free flap there. I later decided to mark this patient to realign the flap accordingly. And I usually take two different sizes of wells or rings, or you can make two asymmetrical circles doing the same thing. Lifted the flap again after taking permission from the patient and ensuring that the flap was not falling in the ablation zone. Um I just went ahead with the ablation. The patient in the left eye had just -2 diopter of spherical error. So it did not take much time there. Later on, once the ablation was done, again, I had difficulty in putting the flap back again and realigning the flap on the surface of the cornea because it was very loose, and any maneuver to make the flap straighten was misaligning the flap from the markings that I had made. So I was worried about the flaps try as well, and I knew somehow that this patient not going to do very well because of the increased manipulation over there with the flap. I'm just trying to flatten the flap and open all the edges, trying to manipulate and place it at the exact location there. And once that is there, I could see flaps try in the center. So I just again went ahead with a bit more of stromal hydration. And later on, I realized that those were not flaps try, but a loose epithelium which was present on the surface of the cornea. And I just decided to leave it as it is. Once the alignment was confirmed, I just placed a BCL and I just waited for 2 minutes, for a couple of minutes to let the flap dry and the flap to reattach well to the surface. And I placed a BCL and yeah, this is just confirming if the flap is very well attached to the surface. This horizontal line just helped me in orienting my flap to the underlying surface. So next day, surprisingly, patient did complain of blurring vision in the left eye. However, he could read 20/20 with effort in the left eye. This was his diffuse slit lamp examination. The BCL, you can see the BCL is still there. There are some deposits underneath the BCL there. This is a slit section. There are hardly any flaps, try, or fold which is visible. However, the stromal haze is visible, which was noticed in the ASOCT. A lot of haze there. However, there was the flap interface was not very convoluted or irregular that you can see from this picture. Over the period of time, this is 1 week ASOCT picture, the haze reduced, and this is a 1 month picture where the haze had drastically reduced. And the patient still had 20/20 vision in the left eye, but he was not very happy with the left eye, probably because he knew that something has happened in the left eye. He was not very happy with the left eye. And this is the last visit picture. There are a few metallic debris that can be seen and probably a couple of microstri, mud crack appearance there. I just took permission from him at my 1 month follow-up visit, and he obliged for the picture. This is his eye. It was very deep set eye, and I find this picture very scary. As if he's just glaring at me and just telling me that this is something that you've done to my left eye. So thank you all.
Excellently managed, Dr. Vivek. That again goes to say, I think if free